Lovely. Grace, thanks, Mel, Uruj, and the whole team for coordinating. And my goodness, 61 people joined. So impressive high numbers, and again a testament to the organization behind this, and also the interest in this therapy choice that, as Grace has outlined, vital and can return people to make the choices that they want rather than limiting the choices they want to make. The tirzepatide is the medication really that feels like has had a lot of press before this. I work both as a consultant at St George's in diabetes endocrinology acute medicine. I work in the community in Wandsworth as the diabetes consultant, and I'm also the Southwest London cardiorenal metabolic diabetes and healthy weight lead. So a few hats, and that's the hat most relevant for this. I've been using tirzepatide, as a lot of you have already, for diabetes, but talking about tirzepatide or Mounjaro for obesity is the mainstay for today. And this is being launched in the next week or so. So thank you to all those already prepared and perhaps ready. This is an injectable therapy that is a dual receptor agonist that's licensed for initiation in primary care for weight loss, as opposed to previous iterations. The rollout across Southwest London over multiple phasing, because the numbers who would meet criteria and the phasing to achieve this without bankrupting and drowning clinical services is why there's a phased need, as well as a lot of comms, because there's a lot of people who already want to know and perhaps already affording and buying it. So we need to do this in a way that is allowing the right people in an equitable way to get access to this really incredible, potentially game-changing therapy. Practices will be equipped with searches, and perhaps, Grace, we were already talking about this, and that'll be part of the documents and searches to run to identify eligible patients from within your practice population. And there's already some learning that's been done regarding this in Southwest London, and inviting eligible patients for review and initiate discussions regarding weight management, which isn't always about a drug, even though that may well be supporting people to recognize that a therapy might be part of this, as opposed to perhaps what was considered lip service regarding weight management strategies before. With patient consent, clinicians to prescribe and monitor monthly for the first year. So there is an ask, but with this ask, there are some really impressive outcomes. Were there any questions? I see, will we get slides? I'll let you answer that in the chat, perhaps. If we move on to the next slide. Thank you. So again, there's some knowledge about tirzepatide from the diabetes world, and we're now talking about the same drug, but different indications. Tirzepatide is a GLP1 and GIP dual receptor agonist. It's an injection, and it's weekly. And the patient administers this weekly subcutaneous injection themselves. So under the skin, much like an insulin type of injection strategy, and future slides in a few minutes will show that it's very similar to a modified insulin pen. In terms of weight loss, it can work both centrally and peripherally to induce satiety, so the actual eating behaviors and patterns and drivers. This can help support and reinforce satiety regarding central hedonistic centers that support satiety, want and need, as well as peripheral gut hormone mechanistic elements to support reduction in appetite, slowing the movement of food through the body so people feel fuller, and hopefully reduce oral intake and lose weight. Clinical trials, both for diabetes and obesity, so Surpass and Surmount, have shown that tirzepatide can help people living with obesity lose up to 20% of their starting body weight. So this is incredible percentage weight loss numbers, and is akin to surgical strategies for weight loss surgical approach. But we know that their want and capacity to deliver that to the population who want it and need it is very limited. And this is very important to be supported with accompanying diet and lifestyle support. So these two do have to go hand in hand, I would strongly recommend. The starting dose, and again, I'll touch upon this in more detail in a few more slides down the line, is a 2.5 milligram once a week injection. And this pen can hold 4 injections, so 4 weeks in one pen. That pen can then be up titrated every 4 weeks up to a maximum dose of 15 milligrams. So there's several dose titration opportunities within the first 6 months, which could be even every 4 weeks. And I'm pushing that for certain patients. And the no sort of stopping date, that this is a duration unlike other therapies where once you start it and it's helping and people are getting the benefits, that there is no stop date unless there are harms or side effects, and we can touch upon those a bit later. Next slide, please. Thank you. So again, just I'm a bit more of a visual person. So again, thinking from the top and the middle regarding the way and the how. So thinking about diabetes and insulin sensitivity, which we know if somebody's not insulin sensitive, you have high insulin levels, and that can promote weight gain and obesity. So that can improve reducing insulin levels at the right time. And allow people to lose weight through blood sugar control, even in the pre-diabetes and diabetes population. And Grace will touch upon that inclusion criteria. There are benefits within gastric emptying and reducing anti-insulin or glucagon secretion. So these are perhaps more beneficial for the diabetes cohort or the pre-diabetes. But really for the mainstay for today, talking about the middle part where body weight and fat mass reduction, reducing food intake by reducing the want and the need, reducing appetite and improving the satiety feelings and reducing the hunger feelings. So there are hunger hormones and satiety hormones, and that food cravings, especially for those fast food sweets and carbohydrates that give you a quick hit, but then quickly need top up again, can hopefully modify eating behavior. So fundamental. The idea of saying, only eat when you're hungry and don't eat when you're full are kind of banal things historically to say, whereas maybe this actually supports people to achieve those objectives and aims. And with that modulating fat utilization, the hopes that this can support changing of fat and reducing fat mass. So really hoping that this mechanism of action can support while people are on this therapy, the weight loss that can be achieved only through surgical means historically. I note a question. Should I pose that now, or I'm seeing a nod? Thank you. So rebound weight after stopping, and I would say that some of the weight loss here that has been evidenced is 3/4 fat weight, 1/4 muscle weight. While on this therapy, we don't have any bone data yet. So I would say that pro-muscle preservation strategies regarding the lifestyle choices would be important. Literally weights rather than cardio, and the kind of protein and reducing carbohydrate strategies to support this while on, and then thinking about cessation if there's appropriate to stop. But as I said earlier, there is no stop date unless the patient cannot tolerate it. The negative effects, so I think there were historical concerns about Ozempic and mental health. I think that's been evidence-based. I'm not certain that's been noted with Mounjaro at this moment, but I think Ozempic or Wegovy did have some of that concern. HRT when using this, shall I answer that? Short version, yep, use it. But again, don't use it. Are you saying, Grace?
No, answer at the end.
Oh God, sorry, I'm seeing nods and shakes. Fine, I'll move on then because time's critical for this. Sorry, boss, excuse me. So I think this is over to you, Grace.
Yes, thank you. Yeah, I'm just thinking we've got quite a few FAQs at the end, and it might be good because then we can add them to that as well, so that when we present next time, we'll have a few more questions. So who is eligible? According to the NICE guidelines that were published in December, they are suggesting that people with a BMI of 35 or above and one weight-related comorbidity. Now, the BMI then reduces if from specific ethnic backgrounds, that reduces to 32 plus 0.5, again with one related comorbidity. However, that would have meant that there was around 3.4 million people in the UK who would have then instantly been eligible for this medication, which, as you can imagine, we, number one, don't have the staff resource, and number two, don't have the financial resource. So NHSE produced a funding variation, or submitted a funding variation to the Department of Health, and it was agreed that they would be a staged rollout or a staggered rollout to mainly save healthcare resource. So this is available, this stage rollout or this eligibility criteria is the same across England. So all ICBs are using this staggered weight-related eligibility criteria. Now, this is year one, as you will see on my table here. A patient must have a BMI of 40 or above with 4 or more weight-related comorbidities. Now, there are many weight-related comorbidities, so NHSE have been very specific with which comorbidities they are including in this. So you'll see here on the table on the right-hand side, hypertension, dyslipidemia, obstructive sleep apnea, atherosclerotic cardiovascular disease, and type 2 diabetes. So a patient to obtain this medication on the NHS in the first year has to have 4 out of these comorbidities plus a BMI of 40 or above. And then this criteria just starts to widen slightly as we go through the years. So cohort 2, they still must have 4 or more of the comorbidities, but then a lower BMI of 35 or above. And then by cohort 3, this must be a BMI again of 40 or above, but then just 3 comorbidities. So the main reason for this was to basically stop overwhelm, and mainly in primary care, because we already know that you are very, very busy. Next slide, please. And the next slide. So how to identify whether you in your practice have eligible patients within this first cohort. Yesterday, the LCS was sent out to all practices with an accompanying search. So hopefully most of you have already got that, and I would presume have run the search to see how many patients that you have. Roughly in Southwest London for year one, we are looking at about 600 patients across all of Southwest London. So I'm figuring that some practices won't have any patients, but some of you will have some, but just not many. So hopefully that means that you will find this a manageable cohort, at least in year one and year two, where the cohort's going to be very small. In cohort 3, as the criteria starts to widen somewhat, this is when I've been speaking to many practices, and they're suggesting that they might start looking at running group initiation clinics at a PCN level, where they're not utilising any appointment slots, and they can use their R's roles. So the ICB will share the searches. We'll also put the searches on TeamNet in case you haven't got those. A practice then will, after they've run the search, review the report that the search produces, have a look at the patients to make sure that they're eligible, and that it's safe to manage, and then obviously invite those patients in to ask if they would like to take the medication and have a conversation. We have here the SNOMED codes. These are in the LES, and we would really appreciate you using these SNOMED codes, because this is a black triangle drug, as they're calling it, because it's new to primary care in this format. And so obviously there's safety elements that we want to be able to track, and we want to be able to audit the effectiveness, again, because it's quite a new medication for weight loss in primary care.